asked me about my experience with femtosecond laser use in pediatric surgery. Here are my financial disclosures for 2015 and 14 and 15. Well, what is known already is that we have the technique with the femtosecond laser that's called primary posterior laser-assisted capsulotomy. And we successfully performed this technique also in bag-in-the-lens technology, intraocular lens technology. You know this lens from Marie Tassignon, where the anterior as well as the posterior capsule is inserted in the trunk and the edge of the optic. We then also have published the technique of the femtosecond laser-assisted cataract surgery in infants, as well as in small pupils, as Dr. Ram, Professor Ram already mentioned. And also think this is a good option for Marfan syndrome, for example, because of the challenge we sometimes have in these eyes performing a capsulotomy. So first of all, I would like to show you the technique briefly on the primary posterior capsulotomy. Here the eye is docked already, the lens is already in, the eye is closed, so usually you would leave the patient away, the case is done. What you now do is a rescan with the laser. And you see here that nicely detects the intraocular structures. The laser, of course, is not set up to this to doing this, but here you see the posterior side of the optic. Here is maybe some OVD behind. Here's the posterior capsule, and here what you see is a bigger, pretty much bigger burger space, which has not been detected beforehand. But the reason is supine position of the patient. Gravitation takes place. There's some fluid goes through it and through the zonules, for example, and of course you replace the thick lens for a very thin lens, and you keep the anterior highlight intact, as you have seen. And this is the posterior capsule here. Here's the anterior capsule. This is the posterior capsule, and this capsule disc rolls up within a minute, some minutes, and disappears and will not show up again. It's not individuous and comes up as a floater, so it's away. So what are the aspects and prerequisites in terms of performing this kind of surgery in pediatrics? Well, the laser has to be in the OR. You need good anesthesia equipment for pediatric cases and team. It's an off-label use, that means you have to inform the parents about this, for example. Then, of course, because of the warming of these very young humans, you need a climate system that's sufficient. And, you're doing this under complete sterile conditions. Of course, you have opposing to some anatomical challenges, because you have to deal with small pupils as well as tight pulmonary fissures. And therefore every millimeter counts, of course. And you're docking very small globes, so that this is the inner portion of this docking, this personal interface. And you see the big difference compared to adult. And so we are happy to have different personal interfaces, also one with 12 millimeter that fits into this tight lids. We have different aspects. You can do an unsterile docking beforehand and perform capsulotomy only, or you perform it under sterile completely, and also with the potential to redock. Of course, we are not doing a fragmentation, and I personally am reluctant to perform corneal incisions because often you have to suture these incisions. So we started in December 2011 so far, and we've done 54 cases already, doing an anterior as well as posterior capsulotomy in nearly all cases. If we implant a lens or not is an individual decision. We are doing HD video documentation in every case, and every case is histopathologically investigated by my co-author, Dr. Tim Schulz, who looks for everything as a co-pilot, so to say, and then we investigate the deviation from the target diameter. And this is one of the initial cases where you see here the anterior and here the posterior capsulotomy, but this is too wide already. So we recognize that this is, by the way, a Mayunian ring here after docking. This is a docking view. And you see that there was some capsulotomy enlargement. So it was greater than intended. And And our settings here with this 3D, SDOCT, so it takes into account 3D, even if it's tilted or something like that, it compensates. The anterior capsulotomy with incision depths from 400 to 1000 microns, with pulse energy different because the capsules are sometimes very robust and others are not. And these are the settings for the posterior capsulotomy. The good thing is, if you're performing the posterior capsulotomy, you can align it to the anterior capsulotomy. So it's perfect aligned not only in size, position and shape, but also anterior to posterior. Here again you see that we are saying the system and cheating the system that the posterior capsule is the anterior capsule. But I know that AMO is working on it. So we then measured the diameter and analyzed this statistically and histopathologically. Interestingly, this is the entire disc, but this is a high neck, a typical high neck view. The pathology and the edge quality is so good with the pediatric capsules. You cannot compare this to the adult. And this is the results. Here's the age of the children, and here on the y-axis you see the capsulotomy enlargement factor. So you target, for example, for 3.9 and get then 4.9, depending on the age, because you see the younger tend to have a higher, greater enlargement versus the older. So in conclusion, surgically, the anterior as well as the posterior capsulotomy is very easy. I mean, everybody who can press the button can do it. It is precise, centered, and perfect circular, it's safe. And having done so many back in the lens lenses already, where you know from the wings of this haptics, you really have to stretch the capsule. It's extremely well stretchable, and I've shown this already at the live surgery event at the DOC, which you can look at through our web channel. It's in HD on our channel. Again, the PCT is aligned to the ACT. The CT diameter is greater than intended, depending on age. The younger, the greater the deviation. We therefore published the so-called Bochum, where I come from the University Eye Hospital in Bochum, Germany, laser formula, which is a valuable and proven tool now. You can get the pre-calculated anterior and as well as posterior capsulotomy diameter. Laser cataract surgery in pediatric eyes is successful also in small pupils, as Professor Ram already showed, with the Mayugin ring in place, or any kind of mechanical device, including iris hooks. Yeah, we published that already. And it's also very valuable in intumescent white liquid cataracts. This, that Dr. Ram showed, was not that fluid, but sometimes these lenses are extremely under pressure, and there you will love to have a laser because it makes the 360 cut because it's so fast. Our settings is at about 0.6 seconds, so it's, time counts in this regard. If there is an IOL implanted, the intraoperative primary posterior laser capsulotomy keeps the anterior eyelid intact. Well, we don't know what that means, but that means that definitely that you don't have to perform a vitrectomy if you're implanting a lens, because you keep the anterior eyelid intact. There's no need for an anterior vitrectomy. Currently, Scott, we may discuss this later on, what that may mean for glaucoma incidence or something like that, but I think personally, having done decades now on pediatric eyes, this has an impact clinically. But of course, it's hard to prove that. Secondary sulcus implantation is possible and facilitated, even then for optic capture, which I like, implanting the lens into the cerebral sulcus with optic capture then of the optic through this opening, well designed, well centered, etc. So I see a clear improvement in my surgery, having beforehand 15 years of dedicated to pediatric cataract surgery. Definitely the number of complications tremendously decreased and outcomes also. And I have no financial interest. Thank you for your attention.